Okay. Okay. Thank you, AOC and ORDI for arranging this thing and bringing all of us together. It gives me great pleasure to introduce our moderators. Dr. Nalini needs no introduction. She's a professor of neurology and the head of the neuromuscular services at the
Can't hear you, Anne.
Dr. Nalini heads the neuromuscular services at NIMHANS, the apex institute in the country for neuromuscular disorders. Most of the literature that has gone out of India, majority of them come from there, and she has trained many generations of people, of specialists. So it's great. It's my great pleasure and privilege to have her as a moderator, along with Dr. Mahesh Kamte, who's a professor like Dr. Nalini, but in pediatric neurology, and is a pioneer in North Karnataka. Acute scarcity of pediatric neurologists. He's doing a lot of work there, and he's also interested in neuromuscular work. So on to both of you.
Hello, good evening, everybody. At the outset, I'd like to thank the organizers for giving this opportunity. I welcome you all for this part 2 of the Neuromuscular Symposium, which is being organized by ORDI and AOC. I'm sure all of you would have enjoyed the last session, that is on SMA, HMSN, and congenital myasthenic syndromes. Today we have got 3 important talks by 3 eminent speakers in the field of pediatric neuromuscular disorders. The first is on DMD by Dr. Anne. Second would be on congenital myopathy by Dr. Regan. And last talk will be given by Dr. Bonneman on congenital muscular dystrophies and LGMDs. I request all of you to note down your questions and doubts and put it in the question and answer box. At the end of the 3 talks, we'll take up these questions. The first talk would be by Dr. Anne Agnes Matthews. Actually, she does not need any introduction for the current audience. You all know her. She is the main person behind this 15-week web series on rare disorders in pediatric neurology. Anne has completed her MBBS from the prestigious St. John's Medical College, where she stood first in MBBS. After that, she has done her MRCP-CH from United Kingdom. She has a fellowship in pediatric neurology, pediatric epilepsy, pediatric stroke, and pediatric neuromuscular disorders. She has given multiple international and national innovative talks, and she is a pediatric epilepsy trainer for the PET program, and he's a faculty for EEG or PBP course. She currently heads the pediatric neuromuscular services at Bangalore Baptist Hospital. She's also attached to Sagar Hospital in Bangalore and MS Ramaya Hospital in Bangalore. With this brief word, I'd ask Dr. Anne to give a talk on Duchenne muscular dystrophy. Over to you, Anne.
Thank you, Dr. Mahesh. Am I audible?
You're audible, Anne. You're audible, and slides are also seen very clearly.
Okay. Thank you for the very kind introduction, and thank you, ORDI and AOCN, for the opportunity. I'm hoping to give an introduction to Duchenne muscular dystrophy, a prototype for most of the muscular dystrophies that one sees, and the commonest one. So just an overview of the basics of DMD, something about more of a clinician. The speakers who are coming afterwards, they are great clinicians as well as researchers and academicians. So I'm speaking more along the standards of care and the multidisciplinary aspect to the standard of care, and touching upon at the end on some newer therapies. So DMD, Duchenne muscular dystrophy, this is the commonest muscular dystrophy that we come across. 1 in 3,500 boys are affected. Its locus is on the X chromosome P21, and so it is because it is X-linked, boys are affected. There is progressive weakness, and invariably there is ubiquitous cardiac involvement at some point or time. So females are not generally affected, but this is an important thing, is that most of the many carriers have cardiac disease. And so in a country like ours, where there is a lot of stigma attached to females being the mothers being carriers, I feel we have a duty to insist. I don't know about all of you. I know that our team, we struggle to convince families sometimes, but we are managing to do it more often, convincing parents or mothers that they need carrier testing not just for next progeny, next children planning, but for their own health, for their own heart's sake. So it's the largest gene known to human beings. It's the largest human gene with 2,300 kilobases, 79 exons. And the gene, it's mRNA. The protein is the dystrophin protein, which is present, which is expressed in skeletal muscles, cardiac muscle, and some nerve cells in the brain. So this audience is an august audience, but I do know that there are some students there. So please pardon me for touching on some of the basics. So mutations in the same DMD gene, we know, can cause the milder phenotype Becker as well as the severe phenotype, the DMD, which is based on how badly the functional protein is affected. So it's a degenerative, irrespective of whether it is DMD or BMD, it is a degenerative disease, and there is progressive weakness and wasting. So again, basics, we have, this is the function of our muscles, the structure, a cartoon of our muscles with the ultrastructure, the sarcomere, the contractile apparatus, and under microscope, this is what on histopathology muscles look like. The nucleus, the most important part of the cell in a healthy muscle, is in a polygonal shaped healthy muscle, is pushed to the periphery because the contractile apparatus of the muscle takes up the entire space, because that is the primary function of the muscle. So as you can see, it's all polygonal, almost equal sizes, and with the nucleus pushed to the periphery. And so we have what we call as the dystrophin-associated protein complex, or the DAPC. Essentially, there are lots of these proteins which anchor the sarcolemma, the cell membrane, to the contractile apparatus. This maintains the mechanical integrity of the muscle, whose main function is contraction. If this is disrupted, this is what happens. It's like a vehicle without shock absorber. So if any of these proteins are not working, and dystrophin is the key protein here, then the DAPC is affected, and then you have breakdown. So if you have the dystrophin protein, the key protein, the shock absorber is absent, then you end up with problems with Duchenne muscular dystrophy or Becker muscular dystrophy. So you have your dRNA, the transcript forming the mRNA, and in translation, we have the dystrophin protein produced in the ribosomes, and you have the exons cut out of this 2,300 kilobase gene to give us the mRNA with the exons. This is the cartoon, the map of the dystrophin gene, which I think more and more of us are becoming familiar, because greater understanding of this is what has given us the key to unlocking the therapies for these children with these diseases. So just for some of our juniors, so just to see, the gray cat ran down the hall, original gray cat ran down the ball with the B changed from H, which is the missense, and the green cat ran down the hall is an insertion mutation, and the gray dash ran down the hall is a deletion mutation, and gray cat ran down the hall is a duplication. And the gray, where there's a stop, a premature codon, and it doesn't make sense, that's a nonsense mutation. So we all are aware that there are various types of spelling mistakes or genetic mistakes which can be pathogenic. But what happens in DMD, each disease has a pattern, but DMD is a disease where we know that commonly what happens is the largest type of mutation are the deletions, followed and then duplications. Then you have about 20% or so of them which are point mutations. So we use a platform called as the MLPA, which checks for large bits or pieces of the gene that are missing or doubled, deleted or duplicated, which is our protocol for when checking for Duchenne muscular dystrophy. So we do not ask for Duchenne muscular dystrophy on panels. We ask specifically for the DMD gene and ask for MLPA, because 70 to 80% of them, one would detect it through that. And only the 20 to 30% of them, we wouldn't be able to detect on that. That is a cheaper test, and we are from a resource constrained setup. And so this is the protocols that many of our centers follow in India. So this is a map of your dystrophin exon map, and you have the intact dystrophin protein. If, for example, exon 11 is deleted, then there is no functional protein in the mRNA transcript. The transcript is disrupted. There is an out-of-frame mutation, and you have no protein. Zero protein equals Duchenne muscular dystrophy. Histopathological changes. So this is early change in a very young baby under 5. A baby or an infant whose changes clinically, it would be very subtle changes, but already the muscle biopsy begins to show changes. You can appreciate that it is no longer as sharply polygonal. There is more variation in fiber size. You can see that one of the nucleus has gone inside in the center. So all saying that the contractile apparatus has been disrupted, has been insulted. So this is early and mild change. And you have the more obvious DMD where you have so much of fibrosis, so much of degenerating fibers. So that is the obvious one. So this happens at 10 years of age or later. So as a result is a necrotic degenerative regenerative process. End result is muscle wasting. So this is the classical pattern that we are all aware of, the classical Gowers sign. So Becker, milder sign with weakness, but here too one gets cardiac involvement, but the pattern is different. Usually it is rare to find cardiac involvement less than 16, but up to 70% of them have cardiac failure by 40 years of age. There are always exceptions to this. I remember, and Dr. Foley also would know, that we had a pair of brothers who were Paralympic swimmers, but one of whom who were 18 and 19 years of age, respectively. They were Beckers. They were really strong and ambulant, and they were swimmers. But then at the end of, one of them was on the waiting list for cardiac transplant. So they also need respiratory MDT approach, and it needs greater vigilance on all our parts, taking care of these special group of children. So this is the natural history, and science and advances have pushed this natural history. So we knew that children died without any interference. The natural history was that by the age between the ages of 14 to 18, they all died. But greater intervention. So in the 60s to the 80s, when even without using a lot of steroids, with spinal surgery and increased respiratory care, children survived. So by now, it is almost as we as a specialist, if we have scoliosis, it means we have not done our job right. Duchenne muscular dystrophy children should mostly not get scoliosis if we have taken care of them well. So primary cause of death in dystrophinopathy is cardiac and respiratory. So spine stabilization and steroids have changed the natural history, both with regards to both cardiac and respiratory, primarily respiratory. So natural history versus the current reality. We know that from 14 to 18, even without any genetic cures, we've pushed the reality. These children, Western data, as well as our own centers, we are beginning to see that these children can survive till 40 to 45 years of age, can survive beyond their third and fourth decade. And the oldest person in the world died at 52, which is very, very unusual. But there's that. And so we take care of their steroids. We take care of what happens with the complications of steroids and how it interacts with the natural disease history with regards to the endocrinological abnormalities that it causes, cardiac complications, which we'll touch on more, as well as the respiratory changes. And a small subset of these children also have a specific speech delay, a specific pattern of autism, and some of them do have GI abnormalities. And the really important, this is important for our country especially. We all know that steroids need to be given. But unfortunately, what we often see is that we give steroids, we are hardly able to sustain them for 1 or 2 years, maximum few years. And then there is no compliance because we are not able to monitor, preemptively take care of the complications of steroids. So which means we've lost the window of opportunity. So we lose these children and they end up giving up steroids because of the side effects. Standards of care. I'm going to be harping on this because this is all we do. This is all we as a team do. SOC. So this is a 2018 document which is freely available on the website, or which is published in Lancet, which people all over the world are following, and this has to be adapted to locally available resources. And for us, for us, what we see in India as well, in our country, is that physiotherapy, because we do not have designated neuromuscular physiotherapists, there are a lot of things that are done in good intention. We do a lot of strengthening exercises, lot of eccentric exercises which do more harm than good. So these are things that we are time and again telling all our families. So addressing contractures, but addressing contractures in a understandably using a commonsensical approach. A child who's not ambulant, we must concentrate more on the upper limb than the lower limb. Whereas a child who is still walking and we are trying to preserve ambulation, trying to protect their spine until 10, 13 years of age, then we concentrate a lot more on their lower limbs. But once that boat is missed, then we don't make their life miserable by giving them a large set of exercises to do, because then we lose compliance and they become teenagers, and we need to engage their cooperation with us. So orthoses play a key role as well. And then we'll come to this steroids, prednisolone versus deflazacort, and daily versus intermittent regimen. There are side effects, of course, as we mentioned, and this is why we have a problem with compliance. So the thing that we've learned is that this is a battle that we need to win, but for this, every battle requires preparation. So preparation for us often means that we engage the family and tell them, meet a dietitian, make a diet plan, and imagine. So one of the good things about working in India is that I've noticed when we prepare our families, the percentage of children who drop out, lack compliance, as opposed to what I've seen in UK, in my short 4 years experience there, is that our parents seem to be a lot more motivated. They can really concentrate and do it, but you have to prepare them for it. They will be really religiously follow everything you say about the diet. But if we can empower them to do it, so empower them to say that in the first 3 months, if they on steroids, while it increases appetite, it does not necessarily mean weight gain. So if we give them one of the ways that we often do center is that we engage our pediatric colleagues have been great. We work with the pediatric colleague who rigorously follows up these patients. So behavioral issues, monitoring that, making sure that they are not at risk of chickenpox, vaccinating them with live vaccines before we start them on steroids. And where necessary, because depending on how our endemicity for TB, we check for TB. So this is local protocols. And also we talk to families about long-term side effects, the height suppression. But that does give us a mechanical advantage in that sometimes we tell them that if they are shorter, there were always these dilemmas on whether one should give the growth hormone to them, but we always tell them that if they are shorter, those children walk longer. Those who walk longer live longer. They have better quality of life. There is always a risk of adrenal suppression. This is an interesting thing that has come up, especially during COVID. I'm sure like a lot of our children, even our DMD children, have fallen sick. And I've had phone calls from parents saying, shall we stop the steroids? Instead, the other answer should be that we need to think about giving them stress dose of steroids because they're adrenal suppressed. So this is where engaging with the local pediatric team comes in. Osteoporosis, we are very, very aggressive about monitoring their osteoporosis and bone density and giving them proactively bisphosphonates. So this also assumes that one has the ability to have age-appropriate centile charts for Z scores, which we are very fortunate to have. But as far as I know, there are only 1 or 2 centers in Bangalore that do it, which may not be readily available, but it is something that one needs to think about. So hypertension and diabetes, we often tell our families they don't kill, but DMD can kill, and we prepare them for it. So cataracts, so depending on whether you use prednisolone or Defcort, up to 24% of all children with deflazacort do get cataracts. We're usually able to successfully manage them. So even with a little bit of tweaking of drugs. So as I said, this Cochrane review by one of my previous mentors, Dr. Adnan Manzoor, again emphasizes the point that there is no consensus. It is up to each individual. In certain parts of our country, deflazacort is very expensive. So depending on what is available. So I do know that in the tribal hospital that I practice, I tend to give prednisolone, whereas in Bangalore where I work, I normally tend to give deflazacort. So intermittent regime, 10 days on, 10 days off, or a daily regime, these are some things to be borne in mind, but remember that you can scale up. From intermittent, you can go up to daily, but one can't scale down. So they are, as mentioned, they're largely manageable, the side effects. So this is a topic that is really close to my heart, the DMD and the heart. So natural history is such that there is cardiac failure is the end result, but slowly there is subepicardial endocardial fibrosis. As you can see, there is initial fibrosis. When it takes place, the left ventricular function is well preserved. So by the time dilatation occurs and function is lost, we're already too late. We've missed the boat. So cardiac myocytes in DMD lack dystrophin. There is increased calcium, which causes damage. There is mitochondrial stress and apoptosis. And there is subepicardial fibrosis, myocardial fibrosis, degeneration, fatty infiltration, and all before myocardial dysfunction. So this is our window of opportunity. So the pattern is, first there is posterior basal left ventricular wall, then there is lateral free wall of the left ventricle, and later there might be leaky mitral valves due to papillary muscle involvement. So early diagnosis and anticipatory management, this is what changes the natural history. This is a key part of the 2018 consensus SOC guideline. So yearly cardiac screening is a must, and it starts as early as you diagnose them. So here, last week we diagnosed a child who is 4 years and 3 months, and who we already found has a inferior-basal septal wall GLS abnormality. So that's not something unusual. So it is not that common, but still it is something that we need to bear in mind. So once we diagnose a cardiac abnormality, the cardiologist takes a more active part, and more frequent visits are recommended based on that. So 2D echo is, if we can take away one thing from the talk, I hope that we could take away the thought that we need to do echoes more frequently, and that 2D echo is not sufficient, and that mothers who are carriers need to be screened. So the functional studies have a higher yield. So that's the speckle and the global longitudinal strain, and of course cardiac MRI is gold standard. But the problem is, even in a big city like Bangalore, there are, as far as I know, there are 2 dedicated centers which do cardiac MRI. So Narayana is one of the centers where they have a dedicated cardiac grid for that, as well as a cardiac radiographer who's qualified to do it. So this becomes tricky. So often, and it is very expensive as well. And then the halter, once our protocol is that once we find an abnormality, we invariably put everybody onto a halter to look for any rhythm abnormalities. So this is a video, I hope it plays, of one of our 7-year-old children. Oh gosh, okay. Okay, it's not working. I'm going to quickly do this and play this video. It's a very short video. This is told by my cardiologist. I hope it makes sense to you. But if you can see this thing, what you could see is that the way it is contracting, in each of the contractile cycles, what you could see is that the computer calculates, as you can see here, the axis of the left ventricle is not equal. And it calculates that one particular part of the heart is not contracting as it should. And so this is a more subtle marker. And what we have found out is that majority of our children, so about 17 of our children, we have a data of about a cohort of 104 children, that if you go by the traditional guideline of waiting for cardiac failure of ejection fraction of more than 50%, of our data, our center is only 2.5 years old. For our center, by that token, only 92% of our DMD are abnormal. And if you look, only 8% of the DMD have an ejection fraction of less than 50%. So this larger number is also including Becker. That's a more heterogeneous group. But if you look at GLS tells us that under 18, 53% of this group is abnormal. That's what GLS tells us. And GLS has made us more prepared. And what we also found is that we found about, in our cohort, less than about 3 children under 5 years who had echo abnormalities who are on treatment. But these were all with large deletion, including the 4-year, 3-month-old baby that I mentioned. That child had a very large deletion. Entire exon 1 to 79 was deleted. So we are thinking a contiguous gene, and we are waiting genetic studies. So we have had 17 CMRIs done from our center. Everything has been concordant with our echo and GLS, giving the message that echo and GLS is really, really very sensitive. Our cardiac protocol means echo initially with GLS, and if there is any abnormality, ECG always done and 24-hour halter. But by 10 years of age, everybody gets put on an ACE inhibitor. And there is, as part of all this, respiratory surveillance and early scoliosis care. Hopefully, we don't need to take care of scoliosis. We can avoid it. And also screening of carrier mothers. So respiratory care, there's a complex relationship. It may indirectly affect the heart, And we do know that there is worsening pulmonary weakness. So this needs to be monitored preemptively, including PFTs, sitting and lying down, and sleep studies. And there may be role for antibiotics. We vaccinate all our children for pneumococcus as well as yearly flu vaccine. So the physiotherapy we've already mentioned. So this is just to emphasize. I do not want to go into the details of all of this, but I just emphasize the one element of this, which is the cardiac, and to say that this is the backbone of our services, including adult services, so including our adult neurologists and transitional care for older children. And this is our team: our endocrinologists, our pulmonologists, our neurologists, our spine surgeon, our orthopedic surgeon, both of us are the pediatric neurologists, our geneticists, our pediatric surgeon, our intensivist. This is our ORDI team member who runs our center, and our physiotherapists who are key members, as well as our cardiologist who has kindly lent me some of these slides. The videos are courtesy Dr. Saravanan. So coming very quickly on our interventions on newer therapies, on looking at HOPEs, they are basically targeting a primary lack in the dystrophin protein. So either the protein that is absent is delivered either through gene therapy, or the reading frame is restored somewhat partially by exon skipping or through nonsense read-through therapy. So there are also other strategies of reducing or mitigating the secondary and downstream pathological mechanisms. So antisense oligos. So these are single strands of DNA. What it does is it complements the DNA, and it sticks to the mRNA, and it ensures that disease-causing product proteins are not produced. So as of now, there's a lot of hope held with ASO and with looking at the exons. So not all of them are skippable, but we think that about 80% of DMDs can be skippable. So FDA-approved ASOs are majority of them. These are the list of current FDA-approved ASOs. As you can see, most of them are in the field of DMD. Only one is in Spinraza for SMA treatment. So eteplirsen was the first thing that was approved. But we all know, so many of us in the field would know, that exon 51 skipping, 53 skipping, 45 skipping. So if you look at this, their 51 skipping works here. You have your 53 skipping and you have 45 skipping. But we do know that they have variable amount of dystrophin expression in the muscle. So they're not the same. As you can see here, golodirsen and vitolarsen both skip 53, but they're not the same. But they have been proven to be efficacious and reasonably well tolerated, which is why they have been FDA approved and are presently in the market. So DMD, nature has given us a good example that there is a milder phenotype with a well-preserved reading frame, somewhat preserved reading frame. And that's how we know that even there is exons are missing and no protein is produced, instead, in Becker, a shorter, functional, truncated protein is produced. So that's the basis. So you have in normal, you have everything, all the exons are present, whereas if your 45 is deleted, you have an out of frame mutation, whereas in Becker, or if you are giving an oligo to mask the 44, 43 and 46 attach themselves to create a truncated but restored reading frame, albeit shorter functioning protein. So this is what eteplirsen does. So 48 and 52. Shortened functional protein with the 51 skipping. So Translarna, this is to make what it does is, for point mutations, it makes the ribosome less sensitive to the stop codon. And so it increases more efficacious production of full-length dystrophin protein. So this has been approved. FDA approval is pending, but approval is only there in the European Medical Association as well as in Brazil. So our own Dr. Nalini's center has been doing this work with this as part of the trials. So this is an oxidaiolase, and initially, so I'm interested in the history of this. That this was partly funded by a parent support group, PPMD, who then encouraged Dr. Lee's lab in Pennsylvania. And then initial reports are disappointing, mainly because there's so much of challenges. There's a heterogeneity of patients. You're picking people who are ambulant at different stages of their natural history. So this is where all the challenges come in. So FDA approval was declined, but it's still, people are working on it. So gene therapy is, the challenge with gene therapy is that the dystrophin gene is the largest gene known to man in human beings. And again, there is work funded by the Muscular Dystrophy Association, and is currently being investigated in animal models and canines. And so this is an investigational molecule, mainly chosen because of its affinity to muscle tissue, and it's AAV9 virus associated one. So there is mini dystrophin versus microdystrophin, depending on the size of the protein that is packaged into the gene, into the virus, to be delivered to the host. So quickly touching upon the dilated cardiomyopathy, there are studies targeting the heart, where an investigational drug trial, the HOPE-DMD trial, where their single intracoronary dose of allogenic cardiosphere-derived cells are injected. So mitigating downstream effects, we all know about the deflazacort. Anti-myostatin is another such molecule. What it does is, naturally this molecule inhibits myostatin pathway. And myostatin puts a full stop to muscle proliferation. So we don't want, already these are diseased muscles, so we don't want myostatin to work. We want at least some muscle to proliferate. But unfortunately, what we've realized is that in atrophic muscle, there's very little muscle mass. So there is very little myostatin for anti-myostatin to work in. So this trial was terminated due to lack of efficacy. Vamorolone is another steroid analog, which reduces inflammation and downstream effects, but has less steroid, is a steroid sparing agent. So there is less osteoporosis, less insulin resistance, less adrenal suppression. It has been granted orphan drug status and has been FDA fast-tracked. Utrophin is another such molecule, which can maybe take up the job of dystrophin. As you can see, dystrophin is our shock absorber here, and utrophin is similar, but it's present in the fetal state. So regenerative medicine with stem cells, we are very far away from making it work, but we hope that one day it will work, that we can force or encourage these cells to go back to their natural progenitor state and make them into healthy myocytes and cardiomyocytes. So the DMD Inspire trial is ongoing with the University of Minnesota with the human iPSC trial, where they are aiming to replace diseased muscle, but this is not in human stage. This is still awaiting clinical phase 1 trial to start. So funding, again, meaning that all of us all over the world have to hold hands to make this work. So lots of issues with iPSC. There is loss of genomic integrity and carcinogenicity. And this is ICMR guidelines, which forbid that we are a country as a whole where there's we've gained a lot of notoriety with the use of stem cells, not always in good taste or in the right context. So personalized medicine is the future. So this is very far away science fiction stuff, but there's something to be aware of. CRISPR-Cas, but we are very far away from it. Ethical concerns, off-target effects of carcinogenicity. I'm concluding, this is my last slide, saying that there are a lot of and challenges for NMD work in India. We have a wide variety of healthcare settings, and accessibility to healthcare is also, because of the geographical, the large geographical nature of our country, and access to healthcare is difficult. But one of the strengths is that we are a young, growing economy. People can come up with newer solutions. We are emerging parent support groups, and pharma companies are showing renewed interest in Indian economy. So there is a lot of diversity. Maybe this means that there can be a lot of public-private collaboration. This is our version of public-private, our version of collaboration in Baptist Hospital, which is a missionary a charitable hospital. With ORDI team, they give us manpower help, and as well as other logistical help, and that's how we work. Thank you.
Thank you, Ann, for this very comprehensive and practical talk on DMD. We'll be taking the questions at the end of all the 3 talks. It's my privilege to introduce Dr. Regan Foley for a talk on congenital myopathies. Dr. Regan Foley has graduated from Georgetown University School of Medicine. She has completed her child neurology and neurology training from the prestigious Children's Hospital of Philadelphia, CHOP, and the Hospital of University of Pennsylvania. She has completed her fellowship in pediatric neuromuscular disorders by Dr. Karsten Bonnemann at CHOP, a clinical research fellowship with Professor Francisco Montoni at Dubowitz Neuromuscular Center, Roche, London. She has completed MD research degree focusing on the collagen 6 related dystrophies at UCL, London, and then worked in as a neuromuscular specialist at Children's Hospital, Dublin, Ireland. Currently, she works with Dr. Karsten Bonnemann within the Neuromuscular and Neurogenetic Disorders of Childhood section of the National Institute of Health. She has served as an investigator for the section's phase 1 clinical trials on collagen 6 related dystrophies, LAMA2 related dystrophies, MTM1 related myopathies, and giant axonal neuropathies. With this brief introduction, I present you Dr. Regan Foley for a talk on congenital myopathies. Over to you, Dr. Regan.
Hello everyone, Dr. Ann, this is Shreya here. So there is a slight a problem with Dr. Foley's and Dr. Carson's system to share the PPT. So what as an alternative we have done is we have created a link for Zoom meeting, which they are okay with. I will share the details of the Zoom meeting in the chat box. Sorry, this is last minute, but I will share the details of the Zoom meeting in the chat box. We all can leave this platform and join in there. So in next 5 to 10 minutes, we can start the talk there if that is okay with everyone. Dr. Ann?
Thank you, Ms. Shreya. While you're sharing, how often do we do bone density? There was a question, Dr.
We have to log in again now after we log out from this platform.
Dr. Nalini, please log in onto the Zoom invite that I'm pasting in the...
So have I to go to the, where are you pasting it?
In the chat box, ma'am.
Okay.
You can just click on the link and join via Zoom.
Okay.
I request all the participants to kindly join using this link.
This is Dr. Foley here. I don't see the link just yet. I don't know if I don't
Ma'am,
have...
I have emailed it to you.
Oh, great. Thank you.
Yeah.
Thank you.
Shreya, just a suggestion, Ms. Shreya.
Yes, darling.
Because we are changing the link in the end, it might be better if people don't log out because there are already questions here. We're taking the questions in the end. So it is okay to keep both open, isn't it?
Sure, ma'am. Sure. That is okay. However,
we just have to keep the videos off.
It is not yet sent. Be on this as well as on that. Everybody is asking where is the link.
Yes, even I am not able to view the link.
Just a second.
Can you put in the Q&A? Q&A is visible.
Yes, ma'am. I'm just putting it in the chat box.
There's a Q&A which can be seen. I can't see the chat.
Just a minute, ma'am.
We should have blocked him and come Kannava.
Are you able to see it now?
No.
In the Q&A?
Fine. I do not see it yet.
Can you see the link, Mr. President? Shreya, can you see the link? Mr. President, I've sent it me and
I can't see.
Is it on our email? But here I cannot see on the screen.
I don't know how to make it. It's coming only to no link. How do I send the link to everybody, to all the participants?
No, I think you could send it.
I've also put it in the...
Mr. President, I've sent it to you. I just cut a copy paste because my WhatsApp is open. I cut copy pasted it to the link on the chat.
And you can put in the WhatsApp group 1 or 2 also, so people can share with each other.
Which group?
I have a WhatsApp group and Shirol also has a WhatsApp group.
You have now so many, 2, 3. You can just put it so they can all share with each other. Because I already put it in the queue. I can't find it still.
I think we can see the link.
Are you able to see the link?
This is Dr. Luthi here. It's in the message box. We can see the link.
The chat box. The chat box.
Chat box. Mr. Shirol has just pasted the link.
1 sec. Can't see.
Dr.
Dr. Foley,
Shreya, I can't find it.
I just don't share my screen.
Sena sir, could you please mute all the participants?
Yeah.
Dr. Foley,
Yes, I'm here. It just says I need you to give me permission to share the screen. Make me a co-host, actually.
okay. Sena sir,
Yeah.
you will have the
Great. Can you see my screen?
yes, ma'am. We are able to see your screen.
Perfect. Can you hear me okay?
There's a little echo in the background.
Why that would be, I logged out of WebEx. Is there still an echo?
Yes, ma'am. Are you using earplugs or your system audio?
I'm just using my system audio. That's what I usually do.
Could you try with the earphones? I think that.
One second.
This is Carsten Bornemann. Are we switching to Zoom or what are we going to do? Because I also can't see slides and I can't share.